Guys, if you're interested in bespoke audiology and tinnitus treatment, you need to watch this video. Hey guys, welcome back to the Dr. Cliff Show. I'm Cliff Olson, Doctor of Audiology and founder of Applied Hearing Solutions in Phoenix, Arizona. And I am joined today on the show with a very special guest, Dr. Brian Fligor. Brian, thank you so much for coming out to Arizona and being on the show.
Cliff, thank you. Thank you so much for having me out.
You're very welcome, very welcome. So why don't you go ahead and start by telling the audience a little bit about you and your clinic and what you do.
So I'm an audiologist based in Boston. I have an office in downtown Boston and also in Beverly, Massachusetts. It's Tobias & Petit Hearing Wellness is the name of it. And we're a full service, private practice, freestanding clinic.
Well, we are at the very end of November, so I imagine that the weather out there in the greater Boston area is a little on the chillier side compared to what we have here in Phoenix, right?
It's a little bit chillier, yeah, like about 30 degrees. Yeah,
there you go,
difference.
there you go.
Yeah.
So we actually went on a run this morning together, the Central Phoenix Mountain Preserve, gorgeous area. We actually got going when it was a little darker and then the sun started coming up. But you're actually doing some training for a pretty big marathon coming up.
Yeah, I'm training for the Boston Marathon next April 15. I'm running this for the Progeria Research Foundation. Got a bib, have a couple of friends who have done this before, and they invited me to come join. That is very gracious of you to say that we went for a run. You ran and I just tried to keep up.
Yeah, right. Well, you know, I was pretty fresh. I'm not in the middle of marathon training, so I probably have that advantage over you. You're probably getting the miles in pretty much every day at this point.
I'm a little bit sore, I will say.
Yeah,
but
right
the run this morning was awesome. Gorgeous space.
That's great. So now, the reason I bring that up really is because progeria is actually a condition that has something to do with hearing loss as well, which is actually, like you said, one of the reasons why you're participating in the Boston Marathon. So explain to everyone watching what that really is.
So the Progeria Research Foundation is a foundation that's based in Peabody, Massachusetts. They help to support the research that is around figuring out what is the underlying issues with progeria and how to treat it. This is a very rare genetic condition that causes children to age rapidly. Back when we first started doing this work, it was around 2007, the average lifespan for a child was 14 years, and they would die of either a heart attack or a stroke. And they're very small, very frail, but they look like they're advanced elderly. Well, it turns out they don't end up with an age-related hearing loss, like what we oftentimes see with our typical patients in clinic. They have this odd conductive hearing loss that progresses as some of the connective tissue disorder progresses as well. So it was an interesting bit of work that I did back in the late 2000s as part of the team when I was on faculty at Boston Children's Hospital.
That's very cool. So I believe it is, you're doing it for charity then.
Yeah.
I imagine there's a link that people could donate if they wanted to.
If people would like to donate to my running of the Boston Marathon for Progeria Research Foundation, we'll make sure that there's a link in the comments.
Very cool, very cool. So thank you for that. So let's talk a little bit more about your clinics and really kind of your journey into audiology, because when we had dinner last night, your journey is different than what most typical audiologist journey is into practicing. So kind of give us a background understanding.
I became an audiologist because I remember back when I was a child sitting at the dinner table, my father having really bad tinnitus and it bothering him pretty badly and not able to really be part of the family dynamic. He's just really into it. He's a vet. He was a corpsman in the Navy back in the early 60s. And I remember just feeling really bad for him and our family doctor having really no guidance for him. And so I became the audiologist that my dad should have had.
And so you grew up actually in Ohio. And so what was the story of you getting from there out to the Boston area?
So I knew I wanted to do something in the medical field. What exactly that was, I wasn't entirely sure. I was directed to a 6-year medical school program. So right out of high school into a rapid undergrad and then into medical school in Northeast Ohio, Youngstown, Kent State University. They had a consortium program. And something about that just felt like, wow, I'm getting shuttled right into becoming a family physician, which would have been great, but I just felt like I wanted to do more. I mean, I'm an 18-year-old kid, and I kind of wanted to figure out my way. So my brother, who's an electrical engineer turned lawyer, recommended, well, try engineering. That's going to set you up.
Is he older than you?
He is 2 years older than me. Thank you. So my older brother, who was going to school for engineering, said, give a try to engineering. This is going to be something that's going to help to direct you, whatever you end up doing. You may not be an engineer, but that's going to help you just move along. So Boston University, out in Boston, had a biomedical engineering program, and checked that out. I said, wow, this is pretty neat. So going from the cornfields of Ohio to Boston, Massachusetts, it was one of these, Toto, we're not in Kansas anymore.
Oh yeah. Totally.
That was a big wake-up call. But I did. I went and I got my degree in engineering, and through that pathway, I discovered that there was a clinical direction to the bioacoustics research that I was doing in my engineering program. It was all about binaural hearing and perception of the direction where sounds were coming from.
Was that just by chance?
It was all by chance.
Yeah, interesting.
Still, at the same time, in the back of my head, it's something having to do with ears, hearing, and the fact that they're just, at least in my experience growing up, I was not familiar with what kind of treatments could be given to people who had hearing issues, whether that be your standard hearing loss or tinnitus or hyperacusis. And growing up where I did, there were a lot of firearms. A lot of people had a hunting license. We used to go to rock shows. I started as a rhythm guitarist in a number of bands when I was a teenager. And so I exposed myself to a lot of high-level sound in kids' basements, and then playing in garages, and then playing some shows. I developed tinnitus when I was 14. And I felt pretty bad about that, given what my dad had been going through.
Yeah.
So all of it just kind of fed into one direction of, this is what you ought to be doing, Brian. Luck.
Yeah.
Or fate or something directed me down this path where I am.
So you end up getting your undergraduate then in biomedical engineering, and then what was your next steps after that? I mean, because I imagine you could have just stayed in biomedical engineering and worked for a company developing stuff, whatever engineers do, right?
Well, the reality is I ran screaming from engineering. It was just one of these, like, this is neat, interesting stuff, but oh my goodness, just in a lab, working on things over and over and over, and especially just given how brilliant some of these people are, it's really hard to keep up with them. And I thought I was a fairly smart kid growing up. Nothing compared to the kids from MIT,
Is that right?
or those people who are in the PhD programs, the engineering PhD programs. And so I wanted to find something that really matched better with what my skill set was, and that was audiology.
Yeah.
So I applied to a number of different programs around Ohio, Ohio State, applied, of course, to BU, applied to Central Michigan
But not
University.
Boston College, to be clear.
To be very clear, friends don't let friends go to Boston College if you're at Boston University. We do not cross paths, not nicely. We did on the rugby pitch. I will point that out. And yes, we did beat Boston College. Every year I played against them when I was at BU. But I digress. Boston University had a research fellowship for me. They had a clinical PhD path. At the time I did this, there was only one university program that had the Doctor of Audiology, the AUD, and it was very new. And I had been advised by a couple of mentors, go with the PhD, and if you want to go clinical, you can do that. So I was right on the cusp between the PhD and the AUD. I went a PhD route, and I'd like to think that regardless of which path I went, it would have worked out pretty much the same.
Yeah.
It so happens that I have a degree that's been around for centuries, as opposed to a degree that's been around for decades.
Right.
Yeah.
And so what was your focus then with your PhD?
So my focus was on recreational noise-induced hearing loss. So when I was a graduate student at BU School of Medicine, which is where I did my PhD, we did all of our clinical rotations through the inner city hospital. And there was a young man who came in, he was 14 years old, reflecting on this, as a 14-year-old who gave myself tinnitus.
Yeah.
14-year-old came in and he said, I can't hear out of one ear. And so I look in, and he's just got a big plug of earwax. Okay, well, that's obvious. But I'm a student, and I need clinical contact hours. So rather than remove the wax, I tested his hearing, and then I was going to remove the wax just to show what it was. And so he had a predictable conductive hearing loss due to the earwax, which just like an earplug, had that. In the other ear, he had hearing loss that is just strongly indicative of noise-induced hearing loss. He had a mild 4 kilohertz notch. And like, why? Have you been like around a lot of loud sound? No. Do you, what job do you have on the weekends? I don't have a job on the weekends. Do you play a lot of video games? Well, yeah. Okay. Do you listen to music? Yeah, all the time. Oh, okay. How do you listen to music? And he pulls out a CD player, because this is 1997. The iPod hadn't been released yet. And he's like, okay, yeah, I listen to this on my way to school and on my way home and when I do my homework. What level do you listen? Not all the way up. That was his answer, not all the way up. And so he shows me, and it used to be a dial that you'd have a 0 through
to
10.
Maybe 11.
Maybe 11. Spinal Tap taught us that.
To 11. Look, right across the board. 11, 11,
and most of
11,
the
and then
amps go up to 10.
Exactly.
Does that mean it's louder? Is it any louder?
Well, it's one louder, isn't it? It's not 10. You see, most blokes, be playing at 10. You're on 10 here, all the way up, all the way up, all the way up. You're on 10 on your guitar. Where can you go from there? Where?
I don't know.
Nowhere, exactly. What we do is, if we need that extra push over the cliff, you know what we do?
Put it up to 11.
11, exactly. One louder.
Why don't you just make 10 louder and make 10 be the top number and make that a little louder?
These go to 11.
His was at a 9.5.
Oh, geez, yeah.
Oh, see, it wasn't all the way up.
Yeah, it did. He wasn't lying.
Exactly. So his question was, well, if I can't listen that loud, how loud can I listen?
Do you know?
I do now.
Right?
I did not then.
Yeah.
And he asked a fabulous question. So that turned into my dissertation.
No kidding.
Yeah. So I got a bunch of CD players, bunch of headphones, aftermarket earbuds, put them on a Kemar, did the full study, and came up with the 60-60 rule. So CD players, believe it or not, CD players put out higher sound levels than the iPod does.
Is that right?
Yeah. It's actually rather dramatically different. So with CD players, it was, you could listen to 60% of the maximum volume for 60 minutes a day without increasing your risk for a noise-induced hearing loss. So we know that how loud and how long dictates your risk for tinnitus and for hearing loss from noise exposures. So you can go up to a certain level, and up to that level, you're okay. And above that level, then risk starts in. And so I defined what that risk was with CD players. Then follow along after that, we did it with iPods, because we needed that.
Right.
We actually, the iPod, it was an 80 for 90 rule.
Oh, really?
So 80% of max for 90 minutes was equivalent to 60 and 60.
Yeah.
So that stuff hit pretty big in the early 2000s. So 2004, I published the first paper for my dissertation and ended up on NBC, Evening News, CBS, Good Morning America. But the best one was David Letterman.
Oh, no kidding?
Yep. I was spoofed on David Letterman.
Get out of town. You were spoofed on David Letterman.
Yeah.
No kidding. I wonder if we can find a clip of that.
Check out Kenneth Sutton. Dr. Kenneth Sutton. He was the actor, that was the name of the character, who came on in a white lab coat.
Very cool.
And yeah.
That's awesome.
Yeah.
All right, well, that's, I guess that was your 15 minutes of fame back then.
I was in my postdoc at the time. I'm like, that's it. My career peaked.
Yeah, that's
I'm out.
over. I'm just going to retire here.
It's all downhill now.
Yeah. So you get done then doing that research, which is really, really cool. But then you graduate. And so what was the next step for you at that point?
So I was offered a postdoc fellowship at Kresge down in New Orleans. And I was also offered a postdoc fellowship at Harvard Medical School. Well, I'm in Boston already.
Right.
I was married. We're looking at having a family. Do I pick up and move down to New Orleans, or do I stay where I am? Stayed where I was. Sometimes I wonder, was that a good choice or not a good choice? I would have been there when Katrina came through had I gone down. So it's, you know, sometimes fate does direct us in a certain way. But I did. I did my postdoc at Harvard Medical School, did a couple of really wonderful projects, had some amazing mentors through that. Part of that, I was able to go out to Oregon Health Sciences University in Portland, Oregon, and study tinnitus therapies with Dr. Billy Martin and a couple of the other folks who are out there who are just the gurus in this area, just absolutely amazing folks. And so kind of got my chops very early on with some really wonderful mentors. Finished out the postdoc, and our ENT chief at the time kind of had some plans for me, made me the director of the audiology program at Boston Children's. Where I had literally just completed my clinical fellowship year and then a postdoc. So I was the lowest person on the hierarchy, and all of a sudden got launched right over to being the director.
There you go. 5
clinics, 29 staff, and here's this young kid who's popping in all...
Well, if you got it, you got it kind of thing, right?
Those were a few very difficult and a couple of challenging years, some very challenging conversations, and some growing on my part. I had to grow really fast.
Yeah, I know when I was in the military, I was, rising through the ranks, and I had just pinned on corporal, so non-commissioned officer at that point, and the people who were my superiors going through that actually got in trouble and busted down and were a lower rank than me.
Wow.
So now these people who were my leaders became my subordinates. And I had to lead them when they had literally the day before were like, Olson, go do this. Then it was literally flip-flop from that. So, but that was a very good learning experience. Like throwing someone into the fire, I think, is the best way to get them up to speed, and especially in a leadership role, as quickly as humanly possible. Because you will make mistakes. And you probably did make mistakes, right?
I made quite a few.
And that was a great learning opportunity.
Great learning opportunity. At dinner last night, we actually talked about this thing called golden nuggets of learning. And this is something taught to me, that phrase was taught to me by Dr. David Luderman. Dr. Luderman taught our counseling. So the techniques related to cognitive behavioral therapy, which I used as part of becoming a pediatric audiologist and communicating difficult information to families. This wonderful, perfect child you have was born with hearing loss, and this is what it means, and this is what we can do about it, but this is a path you weren't expecting. Those are difficult conversations, and when you do those wrong, you have golden nuggets of learning.
Yeah.
Those are the ones where you're like, I made a huge mistake. I can't believe I just said it like that. You learn from that, and you never make that mistake again.
Yeah.
As director of a program with a lot of staff, very smart people, you step wrong, you make mistakes, you say things wrong, you treat people wrong, and you learn what not to do in those instances. So it's a trial by fire, and hopefully you become a really good leader quickly, and if you don't, you should not have been a leader, and out you go.
True. That's right.
Yeah.
That's right. So what was the culmination of your experience then at Phoenix Children's? You know, because you've obviously moved on since then.
So my culmination at Boston Children's Hospital was writing a book called Understanding Childhood Hearing Loss. I was approached by a publisher at Rowman and Littlefield, publishers in Baltimore, Maryland. They said, this is really interesting stuff you've been on the news for, between headphones and hearing loss and identifying reasons why some children develop hearing loss, others don't. That was some of my research that I was doing at the time. And so basically just put about 7 years worth of my trial by fire down into a 200-page general audience book. And that was published in 2015. Left Boston Children's at the very end of 2013, published 2015. Really wonderful, exciting stuff. But I had moved on from Children's, and I became the chief audiology officer at Lantos Technologies, which was a 3D ear scanning company that came from some IP out of MIT. A mechanical engineering professor there named Doug Hart came up with this wonderful approach to mapping out in exquisite detail shapes. And you could do this with engine parts, you could do this with teeth, and he did. He developed an intraoral scanner for teeth. 3M bought this just before the company that that he had started went commercial. And so after he did this in teeth, apparently one of the hearing aid manufacturers came to him and said, well, you did it in teeth, can you do it in ears? And so he scratched his head and looked at it and said, you got to do it completely different. This is a convex surface that doesn't move. You know, the tooth enamel is hard and it's unmoving. Whereas in the ear, it's soft tissue and there's hair and there's wax and it's dark and it's humid. And he said, we can't do this just with light. We're going to have to use some kind of blank slate to map out the surface. And so his approach was to take a very soft conforming membrane and fill it with a water-based dye and then use a camera to map out the inside of that membrane. And you could do it all the way down to the eardrum and get this exquisitely good point cloud that is the shape of the individual's ear.
It's really cool. So, you know, we do a lot of digital scanning inside of my clinic. I've been a huge fan of adopting newer technologies to do audiology the way that we do it. And I remember when Lantos first came out, and I had to make a decision between, am I going to stick with the Tinnitus scanner or go over to the Lantos scanner? And the way that I had essentially sponsorship got in the way, so
reasonably so.
I had a sponsorship deal with Tinnitus at the time, to where I was creating content around all of their products. My entire clinic is outfitted with Tinnitus, but otherwise I probably would have been a Lantos guy too.
You know, it's fantastic when you have a couple of technologies that work and then you can trial it, and that shows that there's a need for that. It shows there's a need. My experience working at Lantos Technologies put me in front of boards of directors, put me in front of venture capitalists, put me in front of some very, very smart people and some very wealthy people. And sometimes those are the same people, and that's incredible.
Yeah.
You know, these are titans in industry. And the audiology world, the hearing care world, is a little different than a lot of the other medical technology space, between imaging equipment, surgical equipment, implantable devices. The audiology world is different. It's unlike a lot of these others. It's unlike dentistry. It's unlike chiropractic or podiatry. It is a unique animal, and what works in some of these other areas does not necessarily work where we are.
Well, you kind of had this like the biomedical engineering background and the audiology background, which probably made you a really nice fit for that particular product.
It made me a good advocate for the clinical side to the engineering and the R&D team. So I was able to translate to the engineers what it is the clinicians were looking for. And I was able to translate from the engineers over to the clinicians, hey, this is what it can do. And so it was just this neat mesh between the two. So I didn't have to be an engineer, but I did understand what they meant.
Well, that helps, because I can tell you one of the toughest things that I have to do when I'm making video content is taking the engineer type jargon and things that we're doing with the technology and making it understandable to a normal human being, which are usually not engineers, right?
Right. Well, that's a gift. Being able to take complex information and boiling it down into bits of information that is accessible. One of my mentors, and again, it's all about honoring our mentors who helped us to become successful. One of my mentors taught me, if you can explain what you're doing to a third grader, you're going to be successful.
That's great.
Clearly. And it's hard to do. You can explain an engineering term to another engineer, and it's pretty neat, and it's cool, and you can develop some good ideas from that. But to get other people who are not at that understanding of the basic technology to grasp it and see, well, how is that relevant to me? That's some good stuff. And that is hard to do. That takes time, that takes practice.
Now, you've moved on from working with Lantos, but I would like to talk about, you are still engaged with Lantos to a degree right now.
Oh, I am right now. In the hearing care world, adoption of a new technology is sometimes very difficult, and you do need to have some advocates behind you who are some of the groups that have a lot of influence in the field. People who can influence providers, can influence investors, and I certainly give no grief to any of the business folks at Lantos, but I do feel that the path that they had charted ended up not being the most successful. As a result, Lantos did go bankrupt during COVID. Just the investors had pulled their funding. They needed to figure out what to do. Everyone did during the pandemic. And I helped find some new investors. I became one of the co-founders of the new Lantos. We put it together. We worked, came up with a new business plan, and we were making progress through. But again, we didn't have enough influence behind us from the manufacturers, from the ear mold labs. And so it was this is a good technology and it works, but the business model didn't completely make sense, and we didn't have enough groundswell behind it. Unlike Natus, that has a whole library of equipment, and the ear scanner is one piece of a large menu. This was the only thing Lantos had.
Right.
They were completely focused on it, and so it just wasn't financially successful. They closed operations. I now actually own all of the physical assets of Lantos Technologies. So I'm going to keep on using it. My staff are wonderful with it. There's a handful of clinics out there that are diehard Lantos fans. I have enough membranes for us and solution to keep us going for a couple of years. And I actually have all of the background information to be able to continue to manufacture if I wish to.
Very cool.
I'd have to sort out some of the licensing deals with MIT, but there's possibility for that. And if folks are as diehard custom evangelists like I am, that fitting a device to the ear using a custom coupling, whether that be the ear mold itself or the physical hearing aid that is a custom device fitted into the ear, I think that using direct ear scanning is a pathway to doing this that gives people an exceptionally good experience in the process. And so I happen to have the ability to do it using the Lantos scanner, and as far as I know, I'll continue doing it in perpetuity.
Very cool. And we'll touch base on that, the custom aspect, because I think that's a big point that we want to touch on today, because it is a unique differentiator of how you structure things inside of your clinic. So once you got done then working with Lantos, you decided to go off on your own.
I did. So as a student at BU School of Medicine, I would test people's hearing. Depending on how we were going to get them hearing aids, whether they were going to be paying for them privately out of pocket, or they had an insurance benefit that would cover the cost of hearing aids, like a Medicaid type of insurance, which inner city hospital, a lot of folks qualified for Medicaid. There was one clinic that we were very familiar with that was like, oh, they're on Medicaid, we're going to send them to Tobias and Petit. What's Tobias and Petit? Is that a law firm downtown or something? Right. It turns out that Louis Tobias and Bob Petit were hearing instrument specialists back in the 1970s who decided we're going to join forces and we're going to provide care for people in the city of Boston. And they became gurus at billing Medicaid. They founded the practice in 1974. It's been around for a while.
Before I was born.
I was born in 1974, so the practice has been around for 49 years.
There you go.
Exactly. So when I was at Lantos, I had been approached by one of the industry players saying there's a practice in downtown Boston that the second generation owner, daughter of the founder, is looking to retire. Would you be interested in having a conversation? I knew who this was. This was a mentor of mine, Camille Catalano, who sold me the practice in 2018. I left Lantos as an employee. I continued on as a consultant to them, but brought the scanner into the practice with me, and I became the owner of Tobias and Petit, rebranded it Tobias and Petit Hearing Wellness, and hired a couple more staff and opened another office in the suburbs, and been doing that now for 5 years.
What did you have to change when you came in? I know you said you hired some staff, you acquired another location or expanded to another location as well. When I was starting up my clinic, or when I was ready to start into private practice, we should say, I was looking as to whether or not I would purchase a clinic or start my own clinic. And I knew I had a very particular way that I wanted to practice. And so that's kind of the thing that scared me off a little bit from having to go in and purchase a clinic and then change things. So I imagine there's things that you changed. What was that like?
The grass is not greener on the other side. That's all I'll say. So between starting your own practice just from scratch versus buying an existing practice, there's pros and cons to both. Both are very exciting and very risky, and both can go pretty badly. I decided that I was going to buy an existing practice, partly because of the reputation that it had and the patient population that they had historically taken care of. There is that side of me that wants to provide service to people who cannot otherwise afford it. And so that drew me into this specific practice, for one. And for another, I just knew I wanted to be a practice owner. That's what I went to school for, was to own and operate my own practice and call the shots.
Which is relatively rare for most audiologists when they're going through school to have the desire to do private practice.
I didn't know that. This is just what I wanted to do. Back when I was a child, our family physician had taken me under his wing and taught me about what he did and why he did it. I spent time with our local vet, the veterinarian, and learned what he did and how he was doing it. And both were really neat and cool. I happened to come along and see this profession called audiology, and lo and behold, you can own your own practice and diagnose and treat hearing loss and tinnitus and hyperacusis. I said, that's it. That's what I'm going to do. Took me a while to get there.
Yeah.
But, 17 years into being an audiologist, bought a practice rather than starting my own. What did I do differently? Well, I did have to shift the focus from being more of the hearing instrument specialist that was really just geared very much around fitting hearing aids to people, to doing more of a diagnostic perspective and more of a treatment plan perspective. And while the former owner and her staff had done a good job, wonderful job of taking good care of people, I did need to incorporate into it things like real ear measurements, test box measurements, doing more thorough diagnostic testing. And as we did that and I set certain protocols and then expected this from people, I got a lot of people behind me. The existing staff and the new staff said, this is great, what a good idea. Let's go down this path.
Well, that's great. I think that would be the scariest thing, is to buy a practice and then get resistance from trying to improve the quality of what you're doing, specifically through implementation of best practice audiologic care, which is quite obviously the reason you're probably even sitting here, is because of our alignments on that topic right there of doing best practices. But it's hard to do best practices. Like, not hard in the aspect of like doing them themselves, but adopting an entire mindset shift and having all the equipment to do it, and then making sure that everybody's trained in how to do it and do it well, is tough when you're coming into you. That's just not the way that it is when the place started, when you start from scratch like I did.
Right. And that is part of the risks that are associated with coming in and buying out a practice, or if you're not buying the practice, you're joining an existing practice, but your mindset is, I really want to be engaged just in doing the right thing for patients. Again, mentors, I had been trained, what's in the patient's best interest is in everyone's best interest.
Yep.
And I have tested that time and again and continue to come up with that is the correct answer. So what is in the patient's best interest? It is to follow best practice. And we know what best practice is, but you pointed out, change is hard. And in certain professions, and audiology being one of them, change isn't just hard, change can be very scary. There can be a lot of resistance to it. And people who make decisions may say, show me why that's a really good idea. And they may come up with lots of reasons why it's not a good idea. I think that takes a great deal of emotional intelligence on the part of the person advocating for following best practice to find an avenue to make it happen. And whether that is as an employee in the practice building this up and advocating from scratch, or it's the practice owner who says, we've been doing great and I think we could do better. I had the luxury of having supervised a staff of 29 audiologists, pediatric audiologists, who were very, very good at what they did, and they were tough. And they wouldn't just take your word for it, they would test you to say, why should we do things like this? So I was trained.
Well, it helps having that background, that leadership background coming in and then changing things because now you're the leader there. And one of the biggest things about being a leader is, can you inspire change in the people that you lead? And it sounds like you were able to do that. How tough was it really? I mean, because potentially a good leader could come in and really justify, like, here's why we need to be doing these things. Here's how it's beneficial to not just your patients, but you as a clinician as well. I would have to say that if you're good at articulating the value, I think a lot of providers are like, man, it feels good to like use my knowledge and use like actual objective testing and all of that to result in better outcomes.
It really wasn't that hard.
Yeah.
It wasn't. That's highly dependent on the people who are on staff with you. If there are folks who don't share the same value, that's going to be hard. But as long as we share the same values and say what's in the patient's best interest is in everyone's best interest, let's find out as a group what that means. Because there's ways to interpret that. One can say, well, what's in the patient's best interest is that we're able to get people in fairly quickly and provide service to a whole lot of folks. Because if we're spending 2 or 3 hours with every person, but our wait list is 2 months long, that's not very good. That means that we're not taking care of the number of people that we could. And so I'm not advocating that we spend hours and hours with each individual patient if that's really not what's required. But then on the flip side, we're also not going to do a treat 'em and street 'em approach of,
that's the way to put it.
Pull this off the shelf, stick it in the ear, show them how to change the batteries, and out the door you go. Call us if you need something. That's also, I would argue for some folks, that's fine, but it's individually tailored care that is what's in the patient's best interest.
You were talking about using 3D scanning of patients' ears with Lantos. How has that impacted how you run things at your clinic? From I like, it's no secret, I like custom suits. I like to have a suit that is made to measure for me, or a suit off the rack that is altered by a tailor to fit me.
Right.
So it seems like you're kind of going this bespoke route inside of your clinic.
I absolutely am. That is part of my values. What's in the patient's best interest is that they have devices that are made for them, not made for someone. So I grew up in audiology fitting children with hearing aids and hearing protection, and fitting musicians with in-ear monitors and hearing protection. And you go custom, like you just do. That's what you do. You fit custom to children because a custom ear mold is the way to ensure audibility and stability of the device in the ear. The musician, they don't want to have just some device that they pull off the shelf and put in their ears, because the levels on the stage are really high and can impact their ability to continue to be employed. You're damaging your own hearing and this most precious instrument you have when you are exposing yourself to such high level sounds. One of the ways to mitigate that risk is to put in hearing protection and then just feed in through the monitor the sounds that you do need to hear and keep that at a very modest level in doing it. So that was my value set, was we're going custom. Why would I fit anything else to my patients who need to hear better, who need to understand their grandchildren, who need to engage better with their friends, family, and their coworkers? And so when I came into my practice, I just laid it out and said, everybody should be getting an option of a custom earpiece if they're using a receiver in the canal device or a behind the ear type of device. And if we're fitting them with, down in the canal type of devices, invisible in the canal devices, full shells, obviously those are all custom, but let's just make custom available to everybody. That was shockingly easy for the existing staff to embrace, because just articulating it the way I did now with you, they bought in.
And so you have this almost by default, this is what we're going to fit someone with unless we see for some reason to not,
right,
because of a unique circumstance, right?
Right.
And so then you would have roughly what, 90, 95% of people doing custom?
Yes, that is what we do. We are what you might call a high volume clinic. We do see a lot of people. 2 clinics, 5 audiologists. We fit, I'll put it this way, thousands of hearing aids per year. That's a lot of people who need to be cared for. The way that I can confidently say they're receiving a tailored treatment plan is by making sure that the device is fitted to them and only to them. And I do that through custom. So yes, by default, we fit them with custom earpieces, whether it be the mold that goes on the tip of the receiver in the canal, or it be the BTE, of course. That's just what we do. That's how we roll. And when a person struggles with that because they've used domes in the past, oh, of course, we're going to shift gears and we're going to provide the patient with what is right for them. But it's a conversation that we have. We don't just by default fit them with, a one-size-fits-none dome. We fit them with their custom earpiece and then make changes as needed.
Very cool. So now you work with children still, you work with musicians, I'm sure.
Yeah.
You probably still do hearing conservation to a degree. Of course, you work with probably pretty standard, typical adult hearing loss, right? Mm-hmm. You still use that book that you wrote?
I use that book that I wrote quite a bit. So, Understanding Childhood Hearing Loss was a labor of love. Certainly am never going to get rich off that thing, that's for sure. Anyone who's ever written a book that gets a little bit of following but not a huge one knows that your hourly rate for the work you did is not good. But when I see a child, whether it's an infant right up through a teenager, the families get a copy of this book just as part of the whole treatment plan, because I do believe that an educated patient or educated family, that makes for a really good collaborative experience.
Now, I don't know if this is written in the book, but you had a saying that you told me that I believe I'm going to say it right, which Daddy doesn't care who's right, Daddy cares about quiet. Right? Did I almost get it?
You're spot on. No, you got it absolutely word for word. So I have 4 children, ages 9 to 16, and I reflect on my own father who had his own phrases. You don't have to like it, you just have to eat it. There are children starving in other countries, of course. And so I discovered that my own dad phrase was, Daddy doesn't care who's right. Daddy cares about quiet.
I love it. That's classic.
I mean, I am an audiologist.
Yeah, no, it totally makes sense. I love that. So, so when you're treating hearing loss inside of your clinic, very clear, it's best practices. It is a highly bespoke treatment for everyone coming through. You also said that you have this passion for serving communities of individuals who may not be able to afford hearing treatment. What does that look like inside your clinic?
Mm-hmm. So, when people have an insurance that is publicly funded, part of the mandate, the federal mandate, is that if there's a need and they qualify for Medicaid, there's some level of technology that these patients are provided with. It's not the highest stuff, that's for sure, but these are devices that are going to be robust and fit them and help them to be as productive as they can be. And the practice that I bought was built upon that foundation of providing care regardless of who you were. Obviously, our services have to be paid for, and it's not paid for very well by these Medicaid-funded insurances, but they are paid for consistently. I'll work with an insurance company that consistently pays me.
Yeah,
I'll put it that way.
It's the ones that don't pay you.
Those are the ones that we struggle with.
They could have the highest reimbursement in the world, but if they don't actually pay you, that's a problem.
It doesn't matter, exactly.
So,
so we do. We have a very robust Medicaid-funded treatment plan. These people receive the same quality of care as somebody who is paying privately out of pocket. Again, they don't access the same technology for sure, but we also have the opportunity to mentor junior audiologists and audiology externs. And because we don't have to have a conversation with these folks about what their treatment is going to cost,
Right.
we can just slide the extern in or the junior audiologist in to really get very good at the act of fitting devices to people.
That's terrific. That's terrific. So I want to segue here a little bit into tinnitus, because you are well regarded as a tinnitus expert, not just in your area of Boston, but really nationwide, and you could probably argue worldwide. You've already talked about some of your background training with some people who are really pioneers in tinnitus treatment and all of that. But you were actually tagged as an individual by a company named Neuromod to work with these Lenire devices, which is bimodal neuromodulation. Can you give us some kind of understanding of that?
Prior to being approached by the folks at Neuromod, I had what I would call a robust tinnitus treatment program. And it was centered around tinnitus retraining therapy with sleep hygiene, mindfulness, and sound enhancement, whether that be through a pillow speaker or a headband to help to promote access to sound through the auditory channel to treat tinnitus, or hearing aids with tinnitus masking as part of it. That's the work that we were doing, and had fair level of success with it, following a lot of the protocol that was set out by Pavel Jastreboff with his tinnitus retraining therapy, as well as the pioneering work by Jim Henry out at the Portland VA in progressive tinnitus management. And so I had a number of medical professionals around me who would refer their patients to me for their tinnitus treatment. ENTs, oncologists, some gerontologists, and psychologists would be sending patients to me. This is an area that I feel has been underserved within the hearing care community. Tinnitus is a very challenging disorder. For people who have chronic bothersome tinnitus, it can really take over their life. And one analogy for tinnitus is auditory pain. It is very severe in people whose auditory pathways have just accidentally gotten hijacked by this circuit noise that is raging from their ear up to their auditory cortex. There are treatments for it. I was watching my own father as a child struggling with this, wondering there's got to be a way to do something about that. And it turns out there is.
Was there at that time? Like, was tinnitus treatment well developed enough at the time that it would have been able to help your father?
There were avenues. It would have been more around fitting hearing aids off-label. At the time, hearing aids were not indicated under their FDA clearance for treating tinnitus. But audiologists would fit hearing aids to people with tinnitus as an off-label application. And it did work if done well, if done correctly. The hearing aid itself is a tool for a confident and capable tinnitus provider to use to help that person develop a better relationship with their tinnitus. So this was the approach that I was taking. I had an audiology extern from Northwestern University come and join my practice for his fourth-year externship, specifically because we did a lot of work in tinnitus, and this was his area that he was most passionate about. During that time, a company called Neuromod reached out to me and invited me to join with their clinical advisory board for the United States, because they had gone commercial in Europe with the CE mark, got their regulatory approvals to distribute in Europe, and they were looking at getting their FDA clearance. And so in advance of that, they engaged with a number of audiologists around the country who were tinnitus specialists to help them to understand what was different about the United States compared to their experience outside. So joined the clinical advisory board, met a lot of other audiologists who are extremely good at this, learned from them. We tried to communicate value to the company. And when Neuromod got the FDA clearance in March of 2023, my clinic was part of their phase 1, the first 14 clinics that were allowed to evaluate and then fit patients with this Lenire device.
Now, even before then, clearly, you were doing a lot of different tinnitus treatments. And so I think a lot of consumers who have tinnitus sufferers that are out there, and there's a lot of them.
There's a lot.
There's a lot of people with debilitating levels of tinnitus, or people who maybe you wouldn't call it debilitating, but it's significantly impacting their life still, right?
It's a spectrum, but
right,
yes.
But I think a lot of people are looking for, I want the cure. I want the silver bullet that's going to just solve it, and I just do the treatment and it takes my tinnitus away. And then there's people who, if they, let's say that they go through the Lenire tinnitus treatment and they do not see the response that they want, they basically call it a scam right off of the bat, right? The S word, right? And
Right.
Sure, there are probably scams that are out there, but what would you say to someone who is speculating to the idea that maybe the Lenire device is a scam?
Tinnitus is this very complex neurologic condition that is based on some injury to the ear, whether that is subclinical and therefore can't be shown on an audiogram or other type of audiological test, or it's overt acoustic trauma that is obvious on a test. The experience of tinnitus is one that is exquisitely problematic, for lack of a better word, for millions of people. We estimate around 25 million people in the United States have chronic tinnitus. Somewhere between 2 million and 5 million, it's severe enough that they're seeking help. And what kind of help they're seeking may just be going on Google and seeing, well, what tinnitus treatments are there out there? And this is a wild west where I would like for the FDA to be better enforcers of any material that is released saying, this is going to cure your tinnitus. It's going to turn it off. Take this dietary supplement. It'll turn off your tinnitus. The FDA is tasked with evaluating anything that comes out and is available to people to purchase, anything that diagnoses, treats, or prevents illness or injury. As such, tinnitus being a condition that can be considered a disorder, this is something that ought to be addressed by the FDA. Say what you will about governmental agencies, they are here in order to help us to be protected. Okay, it is about consumer protection. It's about protecting our population from scams. Having worked at Lantos Technologies and brought that device through the Class 1 510K clearance with the FDA, I am familiar with just how difficult it is to get FDA clearance. It is shockingly hard and expensive for a company to go through that. The Neuromod device, Lenire, is a Class 2, and they had to go through what's called a de novo process. There had never been another device that had been evaluated by the FDA for being safe and efficacious, as in, it's not going to hurt you, and it's going to work often enough that it warrants the claim that this can help you. That fact alone gave me such confidence that this was something that I should look at as part of how I provide tinnitus treatments. So that's number one, what I would say to people who are really worried about tinnitus scams. One, you're absolutely right to be worried about tinnitus scams because there's a lot of them out there. I have seen so much snake oil in my last 22 years. When something gets FDA clearance, that means that it is safe, and more likely than not, it works. It at least backs up the claim that this can be helpful to you. You mentioned people are looking at, well, is it going to cure my tinnitus? I just want a cure. Give me a cure. There are so many medical conditions that don't have a cure. Migraine, that doesn't have a cure, but it's managed. There are things people do to manage their migraine, whether it be with medication, whether it be with other therapies, that's managed. Fibromyalgia, that is not cured. Diabetes is not cured. We manage these things. Vision, low vision, nearsightedness, hearing loss, these are things that are not cured, but they are well managed. And the idea is, can we take this medical condition and take it from being something that's kind of defining you and then make it just another trait that you're managing as one does lots of other things in their life. Okay? Tinnitus is one of those. It can go from being that single defining aspect of you, and then it can be shifted over to oh yeah, that used to bother me. Yeah, I guess I still have it if I think about it, but most of the time it doesn't bother me. That's where my tinnitus is. I told you I developed tinnitus when I was 14 years old, playing in garage bands as a kid. Turn the amp all the way to 11.
Yeah.
That would cause the drummer to hit it harder. He'd develop, a tendonitis in his elbow as a result. And then, of course, all of us, we would all go to shows ourselves, and we would stand in front of the speakers. I gave myself some pretty significant tinnitus that really got very bad in my early 20s. I was playing in a band around Boston at the time, their rhythm guitarist, and my tinnitus was causing me difficulty sleeping and concentrating. I was getting my PhD in audiology at the time, and my department chair handed me a book and said, read about tinnitus retraining therapy by this guy named Pavel Jastreboff. And I went through and I literally just trained myself. I was patient number 1 for my tinnitus treatment. And I was able to shift my relationship with my tinnitus in such a way that it only affects me when I travel, because that's where I feel certain stress and it's a weird environment. I may not necessarily be easily getting sleep. So that's where my tinnitus will kind of kick up a little bit. But I'm aware of that, and I'm able to shift the attention. When my practice started introducing the Lenire device into our treatment plan, I had anticipated that this might be a really helpful tool, and maybe I'll fit it to about 1/3 of my patients with tinnitus, because it seemed that the ideal candidate for this bimodal neuromodulation needs to have their anxiety well managed, they need to have any hearing loss well managed, and they just happen to have this inability to break their attention off of the sensation of tinnitus, that's the ideal candidate. And so as my audiology extern and I started creating our tinnitus management program and started seeing some patients May of this past year, when we were first able to get access to the devices, we discovered far more people were good candidates than my initial assumption was. I had thought about 1/3 of my patients were going to be candidates and I was going to fit them. It's more like 3/4 of my tinnitus patients get fitted. That was shocking to me. I did not expect to have such a large swing that direction. It happens that way because people really do benefit from this device when it is used correctly by the patient and when it's advised and counseling is done correctly by the provider. So the device on its own will not cure their tinnitus, but the device itself is a fantastic tool in the hands of an expert tinnitus therapist.
And it might not necessarily be the first option for someone who's treating someone with tinnitus, right? Like you
For
have
sure.
someone come in, it's not just because they called and that's what they want. That's not necessarily what they're going to get.
Every patient that we see who identifies as their reason for seeing us as tinnitus, they come in for what we call a tinnitus treatment evaluation. And this is a 45-minute appointment if they come in having had a hearing test in the last 6 months from another group outside. Because oftentimes people have already been evaluated by ENTs and audiologists by the time they get to us. So if they have a really good hearing test that we can work off of, I can just do a 45-minute intake with them. If they haven't had a recent hearing test, we book them for the hearing test and for that tinnitus treatment evaluation. Sometimes in that evaluation, we'll supplement what the outside audiogram had, such as doing loudness discomfort levels with them, such as doing tinnitus masking, minimum masking levels, or doing pitch or loudness matching for them. So we might supplement it a little bit, but this is an abridged addition to what's already there. And we review with them 4 treatment pathways. Treatment pathway number 1 is a very conservative, watchful waiting, where I explain to you what your tinnitus is and what it's not, and what the goals might be, and then discuss with the individual, how does that look to you, and do you think that that's something that would be reasonable? A significant minority of patients look at that and say, no one's ever explained it to me that way. I think I can go out and I can manage this. Oftentimes these are people whose tinnitus set in the last 3 months. So these are people I would call acute tinnitus patients. They have acute tinnitus. Because tinnitus can just recalibrate, the brain recalibrates that sensation on its own and can shift its attention away in those first 3 months. So we don't rush ahead and do any kind of formal treatment plan for people who are either in the acute phase or their tinnitus is bothersome, but it's at a severity that is quite manageable and might be managed by the individual. So that's self-management. Okay, that's pathway number one. Pathway number two is tinnitus retraining therapy, which is about 8 to 12 45-minute therapy sessions where it's either done remotely through Zoom or it's done in person in the clinic, where we look at coping strategies and help to explain how tinnitus happens and how the brain can literally shift its own attention away. That's what I did for myself. Treatment path number three is hearing aids, which is a very important and very effective approach, especially if there is hearing loss. But people with normal hearing, I will fit them with hearing aids. It is very effective and can work. Typically that is combined with tinnitus retraining therapy. So pathway 2 and 3 can be combined. That's what I had for 21 of the last 22 years, were those three pathways. Lenire is the fourth pathway, and this is one that doesn't have to be done in isolation, but if they are a good candidate, I like to do the Lenire first for maybe 12 weeks, maybe 16 weeks, maybe 20 weeks. And as we get through that first 3 months, we take stock of where are you, and we may start to incorporate some of the other treatment pathways.
So it's interesting, order of operations of this. I am not a mathematician by any stretch of the imagination, but in order to come to the right solution for the problem you're trying to solve, you have to make sure that you're going in the proper order. And have you tested out different orders of how to approach it and have come to the conclusion that you are more effective if you use Lenire first before you go through your other options like with hearing aids?
The pathway that we take is the one that we anticipate to be the most effective and most efficient for the individual. All of these, with the exception of the watchful waiting, it's going to cost something.
Right.
You know, that evaluation appointment for us, there is a fee associated with that evaluation, reasonably so, because people walk away with a lot more information than they came in with.
And probably a lot more accurate information than they can find online, including my videos on my channel, because I don't speak directly to the individual.
Well,
right?
sure, of course.
Like, I have to be broad in general with the discussion points that I have when I'm talking about hearing loss and tinnitus. When
Right.
they come in for an evaluation, they get exact information for them and their experiences.
Right. So when we do something that's interview-based and it's communicating out to a large audience, we're communicating in generalities. We are not the provider and forming a relationship with individuals out there who are observing, who are viewing this video.
Right.
Okay. And reasonably and appropriately so. This is informational. It is not healthcare. Healthcare happens when that individual comes in, we form that relationship, and I evaluate what are your goals, what's your current status, and how do we get you from your current over to your goal. And Lenire is a very good pathway for more people than I expected.
Yeah.
It is shockingly effective for the right candidate, and more people are good candidates than I originally expected. Things that make a person a very good Lenire candidate are people who are motivated to have an improved experience with their tinnitus, in large part because their tinnitus has hijacked their attention center of their brain and won't let it redirect attention away. That is the hallmark of an excellent Lenire candidate.
So what would you say that your treatment success rate is, and then what do you consider success?
I love the way you asked that question. What do we consider success? With lots of medical conditions, you can't just titrate concentration of a certain chemical in the blood. Oh, your oxygen levels are better, therefore the treatment was effective. You know, it's wonderful when there are treatments that do that. Like, hey, your blood pressure is down now that you're on this blood pressure medication. That's easy. Lots of other medical conditions, tinnitus being one of them, is very difficult to assess severity. One of the best ways we have to assess tinnitus severity is through validated questionnaires. And there's 7 that are commonly used right now. And of those 7, my clinic, we use 2 of them. They're very robust, but they're subjective. But then so are lots of other ways to evaluate things like chronic pain, migraine, the implication of nearsightedness, for instance. So that is subjective, but it's about measuring quality of life and other aspects related to the impact of the condition. So what do we consider a success? What we consider a success is whether or not the patient feels better. Full stop. What does that mean? I feel better. Well, in our evaluation, when we decide we are going to go forward with clinician-directed treatment, we get an idea of what are our goals. And if the patient says, my goal is for my tinnitus to be absent forever and I'll never hear it ever again, I would describe that as an unrealistic goal, in large part because, well, pretty much everybody has tinnitus. Whether or not you hear it, that's a different story. But that person who says, no, I don't have any ringing in my ears. Oh, well, I guess I do when this or this or this happens, or sometimes when it's really quiet, or, everyone experiences tinnitus. Whether or not it is bothersome is dictated by what your subconscious parts of your brain are doing. So if an individual's subconscious parts of their brain have assigned threat to this otherwise benign sensation that is tinnitus, one reasonable goal would be that your brain no longer assigns it threat. Okay, so if it's no longer a threat, the brain says it doesn't matter. When people experience that, well, it doesn't matter, they do feel better. Their blood pressure goes down, they're sleeping better, they're eating better, they have less indigestion. These are things that we look at and say, okay, you are better. And so that's individually tailored, all about tailored treatment plans, assessing what is a good goal for you. We do tack on to that outcomes on these tinnitus questionnaires. So if an individual on a scale of 0 to 100, they come in at a 44 when they get started with us, it's pretty severe. That's high. And if we see them return to us and their score is a 22, that's a 50% improvement. That's wonderful. Excellent. More likely than not, they are going to say, yeah, I feel better.
Right, highly
Great.
correlated.
Exactly, it is highly correlated. You'll hear me, my patients hear me say this, my staff hear me say this, we treat the patient, not the audiogram. And where tinnitus is concerned, we treat the patient, not the questionnaire result. But that said, that questionnaire result is very effective at helping us to wrap our heads around where are you now and where do we want you to be. So clinical trials for Lenire showed somewhere between 80% and 90% of people had a significant improvement in their tinnitus. The definition of significant improvement was a 7-point decrease in their questionnaire score from their initial to their outcome. Now, 7 points for a lot of people really is significant in terms of I do feel better, but not everybody. And so we go by at least a 14-point improvement, so we doubled that, and do you feel better or do you not feel better? If you don't feel better yet, we're continuing our treatment program.
Right.
Okay. Right now we have 72% of people who have started using Lenire and have used it for at least 12 weeks have reached that level of success. I feel better, and at least a 14-point improvement in their questionnaire score.
And that is in line with the clinical trial data, if I recall.
It's in line. It's slightly more conservative. Their result was 80 to 90%, and I'm saying 72. That's also because my definition of success is a higher bar.
Right.
Yeah.
So that's interesting. I mean, but at the end of the day, like I said before, not a silver bullet for everybody. Like you can't go in with the assumption that if you have tinnitus, and even if it's really bothersome tinnitus, which is really what the Lenire device is intended for, to a large degree, and you're starting to explore, actually it's really beneficial for people outside of that as well, but you can't go in with the expectation that this is like guaranteed, it's going to cure my tinnitus and I'll never hear it again, right? Unreasonable expectation. But it doesn't mean that it's not effective.
Correct.
Right?
And in healthcare in general, there is no such thing as a guarantee. Doesn't matter if you're seeing a heart surgeon or you are seeing a a brain surgeon or you are seeing a psychologist. There are no guarantees that the effort that's being made is going to cure you. And I think that it is reasonable for individuals who are the consumers of the care to get a really good understanding from their provider, what is the likelihood of me getting better? And then the individual needs to make a good informed decision. That's the likelihood. Am I ready to weigh the risks and benefits here and say, you know what? It's in my best interest to seek out the care. That way, you know, hey, if I am part of that 28% of people in Dr. Fligor's clinic who don't get better, am I aware, am I willing to take that risk? Now, I mitigate that by the fact that those 28%, they continue on with therapies that may include hearing aids, tinnitus retraining therapy, other approaches I may refer them on to other providers. And we do. We're not done, and we don't just stamp it and say, oh, sorry, you didn't get better, off you go. No, we have a responsibility to the individual for them to continue with their care.
Now, you've had obviously some probably pretty amazing success stories with individuals who are struggling with tinnitus. You were actually telling me about a radio show that you had done the other day, and one of your success stories, one of your patients, was on there with you. Care to elaborate on that?
Would love to. This gentleman is fabulous, and I'm so appreciative that he's been open about his journey, and he's made it he's given me permission to share his story. And so all of you can check out the radio interview. It was on NPR. The show is Here and Now, which is a syndicated radio show. I think there's about 400 NPR stations around the country that carry Here and Now. So this gentleman, Elliot, is one of my earliest patients who I fitted with Lenire. He has had tinnitus off and on for a little over 20 years, and in the past 3 to 4 years it had become very bothersome to him. His questionnaire score, coincidentally enough, was, I believe, either a 44 or a 46 when he started. And that is pretty severe, but it's not up in the 80 to 92 high 90s. And I do have a number of patients who are up in that catastrophic level. Elliot was not there, but he was pretty severe. He was up there. This is highly bothersome, and it was controlling a lot of his life. Did the evaluation, recommended we could either do hearing aids, we could do Lenire, and he had said, I've explored hearing aids, I've tried things before, I didn't really feel good about that pathway, and I've been watching what's happening with Lenire. I almost went over to Dublin to their main clinic to go get treated, and then that clinic said, unless you live in the UK, we really don't think it's a good idea to try to do things internationally. And it's true. It's very hard to do things like that and maintain a good provider-patient relationship. So he was aware, but that's the level of his urgency to do something about this. So he lives in the Boston area. Boston happened to be one of these first 14 clinics that was able to carry Lenire. About 6 weeks in, he said, I feel like I'm having more good days than bad days. Typically, it would be 6 out of 7 days were bad days, and one day wouldn't be so bad. And I feel like it's more like about 3 or 4 bad days, and it's interspersed. I can't guess why. I don't know why. Well, Elliot, keep on going. How's the Lenire? How's that going? How does it feel? Do you enjoy the therapy session? It's 2 half-hour sessions every single day, 7 days a week for at least 12 weeks. And so it's quite the commitment on the individual's part. Elliot was like a lot of other folks who said, I actually enjoy this. It's me time. I can sit and just relax and just be part of it. I can read, or I can do some crossword puzzles. And it's time for me to just get out of the rat race and just relax. So he's like, I look forward to that every single day. By week 12, one of his questionnaire scores had gone from that mid-40s down to a 6.
Oh, wow.
The other questionnaire had gone from the mid-40s to a 0.
Wow.
The way he describes it is, I probably hear my tinnitus 1 day out of every 7, but when I do, I couldn't care less. So he and I were on Here and Now with Robin Young. She's the host. And Elliot just gave this wonderful description of what his pathway, what his experience was prior to getting this treatment, and then once he started this treatment. Robin actually got to try the Lenire device there on the air.
Using your tongue tip?
Oh, we dipped it in some rubbing alcohol first, you know. But I actually, in that interview, I have a clip of the sound that the Lenire device plays through the headphones. It's almost an eerie but extremely relaxing sound. It's just neat. It's kind of unlike other sounds that people use for masking. I find it to be very enjoyable.
So obviously you've been using the Lenire device inside of your clinic for several months now.
Yes.
I don't know I can't remember when you guys all went to Dublin to do the training for that.
We went to Dublin in March.
In March, okay, so it was right around the FDA approval time.
Exactly.
Then.
That was coincidental.
Oh, okay.
Oh,
okay.
We had made the plans. It was late 2022. The clinical advisory board, those of us who had opted to become phase 1 providers for this, we had arranged, March looks like the time when we're going to be able to go to Dublin, to the Neuromod headquarters, to meet with the engineers, to meet with their clinical team, their regulatory team, and go through a week-long training. And it just so happens the FDA got back to Neuromod saying, hey, by the way, you're cleared. From the time they applied until they got their clearance was rapid. It was very fast. The data were incontrovertible. Yeah. It was exceptionally good work
that was the thing.
Neuromod
When
did.
I made my first video about it, I had specifically waited for clinical trial data on that before I really talked about it at all. Because there were some rumblings about it, there were some videos already being posted about it, but I didn't have all the data from the clinical trials. And once I saw that, I'm like, holy crap, this is amazing. Like, you almost don't see data that good. It almost makes it look like it's been falsified in a way. It looks so good. But given that it was very consistent from clinical trial to clinical trial, and like you said, getting de novo approval from the FDA was like the icing on the cake.
Well, here's what is extremely important for your viewers to understand about FDA and clinical trials. So clinical trials that are going to be used to get FDA clearance have to go under clinicaltrials.gov, clinicaltrials.gov, and if they are on that website, that actually means those data are being received not by the sponsor, the researchers, but by a data safety monitoring board. And this is an independent group that is not employed or sponsored by the company. These are the people who look at it and they look for fraud. They look for data being made up because bad things have happened in the past, and we have made mistakes. Society, we've made mistakes in the past where things have been approved and they should not have been. Vioxx, the medication for people with arthritis that ends up causing heart condition, that's one of those. That post-market surveillance ended up pulling it off of the market. Well, data safety monitoring boards are there to make sure that the data are legitimate and that these are not being cooked up in any way. Now, in a clinical trial, of course, you're looking to see the best possible result. Of course you are. That's reasonable and appropriate, in fact. And so when clinical trials are conducted, the people who sponsor it and run it are looking at who is the ideal candidate. So one of the things they did was they accepted people who had a questionnaire score of 38 or worse. And so there are people who had a score of 37 who were not candidates.
Right.
They just couldn't be enrolled into it. Now, out in the real world, we make a choice. Do I only fit people who are a 38 and above, or do I fit people who are below? I said earlier, treat the patient, not the questionnaire score.
That's right.
And so there are people who have scores that are lower, but I know that they're significantly bothered by their tinnitus, that I do look at this and say, I think you may be a good candidate.
Yeah. Do you think that knowing what you know now and having implemented the Lenire device inside of your clinic, in addition to all of the tinnitus treatments that you were doing beforehand, would you ever want to go back to not having that as a tool in your tool belt?
No. No, under no circumstances would I stop offering Lenire as one of our 4 treatment paths. It has been the single most successful addition to my menu of options that I've ever seen in my 22 years.
That's amazing. I've interviewed several providers who've used it, and it's basically the same answer from everyone, is that they were already doing tinnitus at a high level, already successful with tinnitus treatment, running successful, profitable clinics, and, to bring in something else that kind of, like we talked about, change is hard. So even bringing in a device like Lenire into a already successful clinic is a tough thing to do sometimes because of the change that you have to implement and the staff that you have to train and the additional counseling that you have to do to help them understand that particular treatment option. And so to have access to that, it must be effective for you to want to keep it around.
There are significant challenges with incorporating new therapies into what you do. In my practice, we fit hearing aids, hearing protection, we do diagnostics, we do earwax removal, and we do tinnitus therapies, in addition to a few of these other, helpful, important things. But we do not do vestibular imbalance testing or therapies. We don't do cochlear implants. These are areas of practice where, yes, I'm licensed to do those things, but I'm not going to dabble. No, those are a big deal. Tinnitus is one of those areas where you should not dabble. You can incorporate it into what you do, and in doing so, you should do it both with significant training, with support from your environment, the clinic, your supervisor, your administrative staff, and you should also be mentored. That mentorship could occur in clinic or it could be from outside of. Again, none of us got where we are without good mentors. And so for people who are going to bring in a new therapy into their practice, you need a good mentor in that process when it is tinnitus. We are very good at those things that we do, and when we think of bringing in more, expanding our menu of services, we have to be prepared for that. And the decision I made around it was not taken lightly, and happily it wasn't, because our tinnitus caseload grew dramatically.
Sure. Yeah, that's one of the biggest viewed videos on my channel since I published that video, first talking about this concept of bimodal neuromodulation and the Lenire device. So, and talking about change, I want to talk about best practices here really quick, which is, we had these clinical guidelines come out in 2006. It's been a while. A lot of stuff has changed, both from a hearing treatment standpoint, tinnitus, vestibular, all of that has changed since that time. And I tell every member inside of the Hearing Up Network, which you're a part of, is that when new best practice guidelines come out, we have to change with what those guidelines are. There could be things that we're doing inside of our clinics right now that is considered best practice, but when they review all the research that has been accumulated since that time, we might find out that there is another best practice in addition to, or one of the best practices that is current right now is not the new best practice that we have to be able to change.
Absolutely. I'm co-author on one of those best practice documents. So the hearing care treatment for musicians, I'm co-author of the American Academy of Audiology's best practice document around that. And these best practice documents are living documents. Healthcare evolves. We must evolve. And those of us who are part of the Hearing Up Network, we have to help to promote better best practices. So those of us who are part of this network, and thank you for creating this. Thank you for elevating audiology practice for the sake of us doing better for the patients that we serve. Those of us who are part of the Hearing Up Network need to not only adhere to those best practices and just make it part of our identity as professionals, but we need to help to promote what does best practice look like now compared to what might it look like in 3 years. Because as technology evolves, as our understanding of hearing loss and tinnitus, balance disorder and hyperacusis, as these things become clearer through research and new publication and new ways to treat these conditions, we have to stay up with that. And that's the commitment that those of us who are part of the Hearing Up Network, that's the commitment that we have made.
Well, greatly appreciate you. Appreciate everything that you do, preceding my career by a good 10 years or so, right? And I love the work that you're doing. On top of that, I just like hanging out with you.
I know, yeah. Well, you were a fantastic running coach this morning. We look up to those people who are really good at what they do. Where I'm able to provide guidance or mentorship to folks, that's how I pay back my mentors. And then when I get to meet people who are exceptionally good at what they do, like you are, I'm just going to hop right on. I'm going to follow your lead.
Well, I appreciate you. I have a gift because I give a gift to everybody who comes on the show. You get your very own mug for the Dr. Cliff Show.
Oh, fantastic. Yes, in 2005, when I was spoofed on David Letterman, I was like, that's it, the peak of my career. It's all downhill from here. Well, maybe not. A little extra blip. Thanks, Dr. Cliff.
You're very welcome.
This is cherished.
Very welcome. Thank you so much coming all the way out here from the Boston area. Guys, if you liked today's episode, make sure that you hit that like button. And if you are not yet subscribed to the channel, go ahead and hit that subscribe button with notification bell so you never miss any of our newly released episodes. And as always, we'll see you next time.